Hello, my name is Toby Helliwell. I'm a GP or family physician in the UK and Professor of General Practice at Keele University and the Midlands Partnership University NHS Foundation Trust in North Staffordshire, which is halfway between Birmingham and Manchester in England. I've been asked to do a short talk on the role of GP in PMR diagnosis and care. And my PhD very much investigated diagnosis and treatment of PMR in the community. And in the UK, the vast majority of PMR patients, 80% in one UK study, are exclusively diagnosed and managed in family medicine. In other words, they never see a specialist. This might not be the case in many other parts of the world, but family physicians will still play a key role in suspecting PMR, diagnosing it, and then caring for those who are being treated for it. So, suspecting PMR. This is tricky because PMR can present, especially in its early stages, quite non-specifically. And this is why it can be so difficult for family doctors. I always think about a paper published in 2008 by Professor Bhaskar Dasgupta and colleagues, where they asked 27 experts on PMR to submit features of PMR of importance. And they listed in that exercise almost 70 features. And this illustrates the variety of ways in which PMR can present. And so rarely at the first encounter do people present with those classic features of bilateral shoulder and or hip girdle pain, morning stiffness, raised inflammatory markers, etc. It can be much more insidious. So people might start off with fatigue, unilateral shoulder pain, being a bit achy, etc. They might put this down to just getting older. And many might have normal inflammatory markers, at least initially. This is all in the context too of people in the classic age range, typically over at 50 years old, of having illnesses that might mimic PMR, for example, osteoarthritis, or be taking medications that might cause some of the symptoms, e.g. statin medications, which can cause muscle aches. There is a fairly comprehensive list of PMR mimicking illnesses in another paper by Professor Dasgupta and colleagues in the British Society for Rheumatology paper from 2010. And it is well worth a read. Unfortunately, I don't have a definitive right pathway for diagnosis for PMR, and there is no diagnostic test or diagnostic criteria that I know of for PMR that is 100% accurate. And this talk isn't meant to frighten, but rather to illustrate a more pragmatic approach to be adopted. So firstly, be vigilant and curious in considering PMR in the first place, but also consider the wider possible differential diagnosis, paying particular note to red flag symptoms like significant weight loss that might suggest other possibly more serious illness. Investigate judiciously for those mimicking illnesses, remembering especially in PMR that a normal test doesn't necessarily mean PMR isn't present. And follow up. Arrange further appointments if needed to review, see if symptoms are developing and changing, and reassess. Now, you will see patients who are classical, will respond very nicely to treatment, often glucocorticoid medications like prednisolone, and you can be confident of the diagnosis, and depending on your usual local practice, you can start treatment, and this might depend on where you are in the world. Some places have fast-track services to specialist reviews, in which case use these services. And if being seen won't be delayed, and by that I mean being seen within a week or two, and your patient's symptoms aren't too severe, I'd suggest holding off treatment, if at all possible, as treatment may impact on symptoms and affect how the specialist review goes. Also, in certain circumstances, refer early, especially if the diagnosis isn't clear. Your patients are very young, i.e. below the age of 50, their inflammatory markers are either normal or very, very high, or they may suffer significant side effects from standard treatment. For example, people with unstable diabetes, severe coexisting osteoporosis, and illnesses like that. If you have started treatment and your patient hasn't responded hugely, or you are struggling to wean down the treatment, then again, question the diagnosis, think what else might be happening, think about specialist referral. So even if diagnosis is made by specialists, for many, ongoing treatment and follow-up is usually in family medicine settings. Be fastidious about follow-up to check on symptoms and progress, prescriptions and treatment reduction, and review fairly regularly if you have the resources to do so. Think about prophylaxis too. For adverse effects of treatments for things like osteoporosis and gastric protection, this may vary dependent on local guidelines and any comorbidities of medications or medications your patient already has. Finally, a quick word on giant cell arteritis, or GCA. The American College of Rheumatologists quote a rate of between 5 and 15% of PMR patients developing giant cell arteritis during their treatment of PMR, although quoted rates in some parts of the world are higher. Always screen for this if reviewing your PMR patient, and consider the wide set of symptoms of GCA beyond the commonly quoted ones of headache and visual disturbances. Things like fatigue, loss of appetite, jaw pain, weight loss, or feeling flu-like. This is quite a lot to take in when being diagnosed with PMR, new medications, reducing treatment regimens, etc. But I think it is important that there is a discussion about GCA and our PMR patients are educated about it, because rapid recognition and treatment can prevent irreversible complications of the illness, like blindness. I recommend also sharing some written information about GCA when you are happy to diagnose PMR, so that patients are well aware of it and to seek urgent review if they are experiencing GCA symptoms. I hope this short video has been helpful, and many thanks for letting me contribute to improving the care of people living with PMR. Thanks for watching.